but I suggest we go ahead and get started with the panel discussion while he's on his way.
So we'll open things up to any questions from the audience. Here, please.
Sure. Question really to Matt and others. Wonderful talk, by the way. So in clinic, Mike, Corey, and I, and Mike's group, and a few others, find it, this problem seems like every week. We have patients who have indications for anticoagulants or antiplatelet therapy who are treating, who are helping support, but they get treated for cancer. Based on the information you provided, one could argue that perhaps when we stop antiplatelet anticoagulant therapy, there may be an increase in risk of cardiovascular events, but at the same time, because of their cardiovascular, because of those drugs, they might have increased risk of bleeding. How do you handle that? What kind of data do we have? And you mentioned a clinical practice of stopping those drugs. And I wasn't sure where you see that and how you comment.
Yeah, it's a great point. I think we face that more chronically in our populations. And as patients age with cardiovascular disease, the likelihood of developing atrial fibrillation increases dramatically. And that also is an indication for chronic oral anticoagulation, as many know. I think part of it depends upon what type of treatments they're getting for their cancer. If they're requiring biopsies or surgical treatment, obviously you have to stop those therapies at least temporarily around the times of the procedures to mitigate procedure-related bleeding risk. But depending upon the organ system that's involved with cancer, we have to assess the risk of bleeding and then the risk of thrombotic events. And I think that's a challenge. I think we err on the side of trying to reduce bleeding and forget about the risk of thrombosis for the most part. And so what I've been trying to do in my practice is really say, I'd like to continue these therapies if I believe their cardiovascular risk is high enough. In most cases it is. And have an informed discussion with the surgeon and the oncologist and others involved with the patient's treatment of how we could adjust that. I'd be interested actually in getting David's perspective, however, on radiation treatment, because radiation treatment may be extended over a number of weeks or months and may increase the risk of bleeding depending on the organ class. But I wonder maybe how do you address this in your practice?
We see patients who have needs for chronic anticoagulation, and from a radiation standpoint, we prefer for them to remain on their anticoagulants. Again, they're under treatment for a period of a couple of months. Most of our treatment is not platelet suppressive compared with chemotherapeutic agents. And I think it's important to remember that many cancer patients are also hypercoagulable. So it may actually be extremely important for multiple reasons that they remain. If they need a procedure done, clearly they may need to come off temporarily. But the comorbidities that they have along with their cancer can't be forgotten.
And Eric, your point also really highlights the need for a specialized approach, perhaps in a cardio-oncology clinic type of model that was discussed earlier, because in some cases, the risk of bleeding may wax and wane. For example, they get chemotherapy and they become thrombocytopenic or anemic. It would make sense perhaps temporarily to stop anticoagulants and antiplatelets during that period, but then when they recover, to get them restarted. And I think what we're seeing, and this was addressed in other presentations, is that the survival rate from cancer is much higher, and people are living much longer after initial cancer treatments, depending upon the staging and the type of cancer they have. And if that's the case, the risk of cardiovascular events is more linear, and that may overcome, the risk in terms of, morbidity and mortality from cancer after initial treatment. And so if we stop or completely discontinue cardiovascular treatments, we may, not really intended, but unintendedly, we may actually be increasing the risk of a subsequent cardiovascular event. So we need to keep that in mind and understand that cardiovascular disease is a chronic illness that has chronic treatments that we know are beneficial, and the indications for those may fluctuate and be dynamic based on cancer treatments and response, but we should not forget about that. We should really look at both aspects of it.
Additional comments? Yes?
Just as one of the oncologists in the room, so I would agree with you on that. So we treat patients that have survived not only survived advanced disease for many, many years, and so they're at risk of clotting from their malignancy, they're at risk of clotting from the chemotherapy that we give developing underlying cardiovascular disease. And so our patients seem to be clotting all the time. And so we prefer to keep them as at all possible. Fortunately, most of the treatments we did not lower the platelets, especially if we didn't really have to consider like occasionally, yes, but so I'm in favor of that, but obviously it needs an individualized approach. The one thing I want to throw out, we talked about cardioprotection, monitoring, prevention, and so on, like diphenoxylate. Now this is a drug that's been around for a long, long time. There were concerns when it came out at one point about having a negative impact in terms of the response to treatment in the breast cancer world. That's pretty well been negated. The Cochrane overview came out and said, no, that's not a concern. It's used in the pediatric population, it's used quite well as a cardioprotectant. But it really hasn't gained a lot of steam back in the breast cancer world. And perhaps that's because we're using less anthracyclines. So certainly in the adjuvant setting, we're not using the same degree of anthracyclines as we used to. But I haven't really seen it also been taken up in the sarcoma world, but still use lots of anthracyclines, nor in hematology malignancies. So for instance, with CHOP or CHOP rituximab. So I'm just throwing that out there. You know, it's kind of a drug that's been around for a long time, and we're looking for newer therapies that might be very protective. But where do you think this really fits? Is there a fit? And has it suffered because it's been around for so long? And has it suffered because it really didn't have a home?
Yeah, I think they're both good points. Yeah, I think it suffered because initial data were promising at the beginning, where there's some data on the breast cancer population where there was less response to therapy, so really step back, and also in other studies shown, and maybe an increase in secondary malignancy. So it was like put on the side for a long time, but maybe with new strategies that are implemented now in different cancers, I think there is still space to look at this drug because there are some promising data, and you say in kids that really is used and it's cardioprotective.
Okay. Ravi, thanks for joining us again. Ravi's wearing two hats today, taking care of patients on our service as well as helping us here. You nicely detailed many molecular mechanisms of potential cardiac toxicity of cancer therapies. I was wondering, could you elaborate further on the putative atherothrombotic risk associated with certain tyrosine kinase inhibitors and what the mechanism may be with that, just to follow up on this thrombosis and bleeding axis that we've been discussing?
Yeah, so it was a little bit in the talk, but I think that it turns out that a lot of the tyrosine kinase inhibitors target very specific tyrosine kinases on endothelial cells, like the VEGF receptor. And it turns out that if you inhibit these things, you actually alter the homeostasis of bleeding and clotting that happens as a part of a kind of a normal patent vessel. And so by inhibiting this and throwing off the hemostasis, I think you could just start sort of tipping the balance towards thrombosis. And that's part of the problem. People think that there might be nitric oxide signaling. We know that if you inhibit nitric oxide, you can actually get more clots. And so an attractive idea is that we have a lot of ways to boost NO. And so maybe in the future, it'd be hard to prove in a large setting, but maybe that is a way to potentially ameliorate that.
And also, 1 second, you nicely talked about the potential for pluripotent stem cells and looking at cancer toxicity, perhaps in a dish, early on when you're developing therapies. Is there a model with those types of cell platforms to look at endothelial function as well? I mean, because I presume most of what you're talking about might be electrical or mechanical sarcomere, toxicity, perhaps.
Yeah, so different groups are looking at different types of cell types, and so they're actually taking patient panels, so large cohorts of patients and deriving pluripotent stem cells. And the nice part about once you've got a pluripotent stem cell, you can make any cell type you want. And so right now, the big thrust, particularly at the FDA, is trying to figure out how you can actually get long QT or QT prolongation. And so people have looked at electrical phenotypes and cardiomyocytes as a proof of concept. But there are definitely groups, particularly groups at Stanford, that are looking at other cell types, including endothelial cells.
Okay.
Yes, this is a question for Rob as well. So you talked a little bit about the off-target toxicities and unexpected data for the cardiovascular system. I was wondering if you could give your thoughts on whether or not that provides translational platform for new cardiovascular therapies in the future?
Yeah, I think the fun part about this is you're actually learning a lot about the heart, and you're learning about new pathways that are important to the heart. The trick with off-target effects is they're off-target, and so you don't actually know which off-target is really there. But it's really a great platform that you can take from, actually bedside to bench discovery. But absolutely.
One of the issues that we are seeing increasingly in oncology is this, just brought up, of QT prolongation for many of our drugs. And I guess I'd really be interested in the perspective of the cardiologist about the clinical significance of that, because we are often doing sort of, especially in some of our clinical trials, weekly, monthly electrocardiograms, and the actual risk of torsades or VTAC, et cetera, is, I'm not sure we really understand that. I'd be interested in your perspective.
Well, I think it's a beguiling issue for any level of drug development. As QT prolongation is one of the most widely potential safety risks for any drug, and so most early drug discovery programs require a thorough QT study, as you know, with either normal volunteers or relatively normal volunteers. And going forward, even in trials, collecting regular EKGs like this has somewhat limited value. And I think what Ravi was talking about in other platforms, I've seen even some now where there can be a type of chip that can be infiltrated with myocardial cells, and looking at electrical signaling and so forth can detect this earlier on. You're right, in clinical practice, even some moderate to severe QT prolongation doesn't often result in actual arrhythmias and events, and so that's part of the challenge is, does there need to be some underlying substrate on top of that? And we don't know that, but it's been the major area of class action lawsuits for drugs in the post-approval setting, and so there's so much worry on that right now that the regulatory authorities are going a little bit overboard, but we hope that we can come back to the middle a little bit and find a more rational approach.
For healthy dysfunction, which is asymptomatic, there are 5 drugs which are shown. These are statins, and I just want to know what your practice include. Will it be single agent or combination?
For patients with LV dysfunction, yeah, I don't. What's your? What drug do you use?
Yeah, for asymptomatic LV dysfunction, I think it depends on what they can tolerate. Usually we'll, just based on kind of early solve data, you should initially put on your ACE and ARB, and then try to titrate up your beta blocker as much as possible. That's, at least is my practice. There's probably some variation in the group, but I think we try to get people on the standard cocktail if possible. And if their blood pressure allows, try to really ramp it up to the whole multitude of agents.
And do you consider a drug like spironolactone an MRA only when they develop symptomatic heart failure in that setting, or?
I tend to not. It turns out that if you look at more recent data, looking at benefits of spironolactone earlier and earlier, patients with LV dysfunction are actually having mortality benefits. So
Okay. Oh, so dual antiplatelet therapy for patients who are requiring chemotherapy. Again, I think is what Susan mentioned and others. It really depends upon what you think the risk of anemia and serious thrombocytopenia would be from their treatments. Especially if there's someone who's had a recent coronary stent placement, I certainly like to continue it. I'll have an informed discussion with the patient and with their oncologist and other treatment providers about this, and I'll try to treat them per the recommended duration of dual antiplatelet therapy guidelines that we use in our practice, obviously for acute coronary syndromes and coronary stent placement. But I've been able to find I can actually get people through that fairly well. And that type of therapy also, that if a patient is treated with that just in routine practice, after about 3 to 6 months, if they haven't had a bleeding event, they're pretty unlikely to have that over a longer period of time. It tends to occur more early when they're going to have it. So I think it's safe practice to do, but you have to have good communication among the specialties. And I wanted to ask David a question here real quick. Do we see any further in current practice? Do we see radiation-induced coronary disease with the different techniques you're using now? I mean, I saw a lot of it early in my career when there's still full mantle radiation, but really haven't seen much of it now. Is it prevalent anymore?
Well, it still exists, but I don't think it exists to the same incidence. And again, it gets back to the fact that we've recognized, going all the way back to the days where we gave mediastinal irradiation for seminoma, that it causes coronary artery disease. And we've become much more adept at understanding what we need to irradiate, what is a volume that is at risk, and how to more effectively make our radiation conform to the target to reduce dose to the normal tissues. I do think, though, that this is still an issue, and I was very interested in Ravi's talk as well, because I see there's some very interesting yin and yangs to what we want to do with our treatments for cancer versus what one wants to do to not cause heart injury. And there is a common thread as far as normal tissue injury, which you showed in one of your slides very nicely, which is the cycling hypoxia reoxygenation injury and the ongoing generation of reactive oxygen species that can continue on. We've shown in the lab for several months. And so it's important to understand that even when the treatment is over, it isn't over till it's over, and it isn't over when the treatment's over.
Yeah.
And there may be some unique opportunities to understand the mechanisms of injury, and reactive oxygen species may be a good target. There are actually some compounds that were initially, Erwin Friedrich discovered superoxide dismutase here, and which I think is maybe the most important discovery to never win the Nobel Prize. And there are now SOD mimics that are about to come into the clinic to be used as radioprotectors in treating brain tumors and in treating head and neck cancers, and that may be perfectly primed to study in a primary cardioprotective setting as well.
Yeah, I think that's a great, it's be very exciting to see how those play out. Another question here.
Sorry, I just wanted to say I don't think radiation oncologists are on the hook quite yet.
Or what?
You're not off the hook yet in terms of ongoing issues.
No, I don't think we
Now,
are.
what we're seeing, or I'm seeing in my practice, is patients are surviving their first malignancy only to go on and get a second one. And certainly as a breast cancer oncologist, I see those individuals who have Hodgkin's disease and then have breast cancer. But, they're having breast cancer, then colon cancer, lung cancer, so it's not even one cancer that we're dealing with anymore. We're dealing with people who have perhaps more than one. And so we have to look at historically what they received, what are the new therapies, what are the challenges in terms of treating them today. So it can get very complex.
And it's David's thing that it doesn't just stop when the treatment finishes, right? There's a long-term, there's probably a long-term effect, and there's a legacy effect potentially too.
Thanks. Two very good questions. A reminder for everybody in the audience, the microphones in this room are exceedingly directional.
Okay.
So when you use the mic, you've got to speak right into it, otherwise nobody else can hear what you're doing. Since this panel focuses on mechanisms of things, we are on the cusp of another revolution in cancer treatment, both in primary treatment and combination treatment with radiation oncology, which is immunotherapy, not just antibodies that hit target molecules, but immunotherapy, new ways to activate the immune system, PD-L1 inhibitors. We're looking at the possibility of long-term chronic activation of the immune system, inflammation-related issues. Is anyone taking cardio-oncology into consideration at this point in time, or are we going to wait for the first catastrophe and then go after it?
Well, I mean, there's always been this, it's not really well described, but the role of the immune system in cardiovascular disease, and we know inflammation is certainly involved, but the exact mechanisms are still relatively not that well described. I think we should plan prospective studies where we're actually looking at this as we go and do correlative studies with biomarkers and other assays and so forth to understand this and get ahead of the game rather than waiting to see complications that occur in patients who are treated with these therapies and deal with it after the fact like you're describing. So I would encourage everyone here and others we collaborate with to think outside the box as we start these new programs or, continue with these programs and try to understand that better. And I'm involved with the cardiovascular outcomes trial for different treatments for prostate cancer. We're doing a correlative substudy in exactly that thing, looking at the immune system.
I think it's a terrific point that you raise, and the opportunity is ripe. This idea of investigating cardio-oncology and basic systems to try and find mechanisms is just really an emerging field and something to really watch out for, and I think there should be a call for this type of work. We do know that there's increasing knowledge of the microbiota in terms of cardiac homeostasis, and so it's not that inconceivable that altering the inflammatory milieu over chronically is going to result in something. So you're right, we should prospectively approach this.
Just to comment about that, we already have the beginnings of a microbiome research program here.
Okay.
So that would be a great business collaboration as well.
Sounds like a terrific opportunity.
Sure.
The other question, I guess, totally off the cuff, is I'm basically looking at a multidisciplinary consultative team up here. We have a number of folks from the School of Nursing here today. And I wonder, as practicing physicians, whether you could comment on the role of nursing in surveillance and detection. And earlier we were talking about how there's sort of a divide of lack of communication between cardiology and oncology. What role can nursing play in all of that as well? And Susan, I'd love to hear what you're saying.
A very great point. Thank you for bringing that up. That I think all healthcare professionals are involved in the care of these patients have a major role here. And I think what we're seeing more and more in modern healthcare is that we're doing disease management at multiple different levels. And I think having a system where all aspects of patient care, not only just the key things of their medications, but their experience, the patient-reported outcomes are assessed by different levels of healthcare providers, and we have systems in place to do that. And we have our clinics and our inpatient services set up in a way to support that approach. I think it's evolving, but I think that given the fact that we're all being taxed with new requirements, with electronic health record systems and so forth, there's a critical role right now for non-physician healthcare providers to be involved in these patients' care, to recommend treatments, to work together with the physician teams to make sure that all aspects are addressed, risk factors, follow-up, everything else. So I think we should work on evaluating different models of care like we've done for other disease states where we can integrate all care. Pharmacy, nursing, mid-level providers, other exercise therapists, physical therapists, occupational therapists, et cetera. That's all part of the equation here.
Just a quick comment. So I think nurses play a critical role in the oncology world. Unfortunately, for that to have an practice nurse was very involved in the risk assessment of the oncology drugs that we did. And there's no reason to think that can't also be equally involved in looking at cardiovascular risk for those patients that we treat with these drugs. So in Canada, we're setting up an educational subcommittee for our network. It's actually going to be chaired by an advanced practice nurse.
That's great.
And I'd like to remind the group that the NANCOR study was presented at the San Antonio meeting, breast cancer meeting in December, and it was presented actually by a nurse who ran that study.
That's great.
In Canada. So I think they have a key role in that much to offer. So they have to be very key.
Joe, did you have a question? Sure.
That's sort of an extension of the questions that were just asked. And really, I think that what's been highlighted is that this is really sort of the pinnacle of team-based care in medicine. And I think there are a large group of patients who don't have the benefit of attending a cardio-oncology clinic. And there are several practitioners probably either in the room or listening to the live stream who may not have relationships with the other specialties. So I wonder if maybe both the cardiologists on the panel and the oncologists and radiation oncologists on the panel could maybe just speak for a second about some of the hotbed issues that they think would require communication back and forth. Are there certain either clinical observations, drug interventions that should trigger in one's mind a phone call to other specialists to discuss the case?
Maybe we can just go down. Jim, do you want to start?
So I mentioned one of the issues that I worry about, especially with some of the newer TKIs, that this issue of QT prolongation. So I think that's an area where I could certainly reach out more to get better advice about those drugs. The bleeding risk issues and thrombocytopenia, patients with stents are always a little tricky. How long to stop the agents, how safe it is to stop the agents, but particularly for if we have to do some type of interventional procedure, biopsy, place a stent to relieve obstruction, et cetera. So there's no question. I think right now I'm relatively new to Duke, and also relatively new to EPIC, and so actually just the mechanics of making the connection can be challenging. It was mentioned, I think, early on, one of the early talks, that it can sometimes, or Dr. Dent's talk, it can sometimes be weeks or longer before getting that consultation, which you feel is essential to the care of the patient. So figuring out how to just make the mechanics of the interactions and the speed of transfer of information in patients, I think would be very very positive from my practice standpoint.
Okay. Well, I think it looks Mike's reminding us that we're kind of having to stay on time here, so maybe we can just do one summary comment here and then we can go to our final speaker. But I would just say that we have a model now when patients with established cardiovascular disease undergo any type of invasive procedure or surgery, they get assessed for their cardiovascular risk, and we get hammered by that as a cardiologist in our practice on a routine basis. But I would almost argue that if a patient who has established cardiovascular disease is planned to, is found to have cancer, undergo treatment of whatever sort, by whatever specialty involved with the cancer care, that there would be some communication. Obviously, it would need to be broader for people who don't have cardiovascular disease but could develop it from their cancer treatment, but that's maybe step two. But I think there could be a way that could become more of a standard of care in the same fashion, and that we have communication. And you're right, Joe. I mean, most patients and providers don't have access to cardio-oncology clinics, so we need to think more broadly about cancer when it develops as similar to undergoing a procedure or surgery that requires a reassessment of cardiovascular risk. But I don't want to shut down the discussion, but in the interest of staying on time, I think Mike's going to introduce our patient speaker.
No, thank you, Matt. And so that was a tremendous panel discussion. I really appreciate it. I was going to go ahead and excuse the panel, actually, since you guys have done a great job with this, this talk. I'm going to go ahead and introduce one of my favorite presentations.